أشكر إخوتي في جامعة عين شمس على دعوتي الكريمة للمشاركة في الكورس الجميل ده. والميزة في الكورس إن هو بيغطي احتياجات جميع المستويات سواء ابتدائي أو انترميديت أو أدفانس. وده بان في الفيو توكس اللي قبل كده، وأعتقد إنه هيكمل على نفس المستوى إن شاء الله بعدين. I'm talking now about the use of perfluorocarbon liquids in vitrectomy for hematogenous retinal detachment. The physical properties of these liquids allow us to use them to facilitate things during surgery. They are heavier than water. Some of them actually double the specific gravity of water. They are immiscible with water, and they have a slightly different refractive index that allow us to identify the interface with a low viscosity, allowing easier manipulation than silicone, for example. They have an interfacial tension with water that's high enough to make them make globules, definite globules. They have a low boiling point. Low boiling point, this means that they easily evaporate and easily condense, and this may not be very beneficial except in rare instances for some of them, and sometimes this is actually a harmful character. The typical use of perfluorocarbon liquids is the giant retinal tear. Actually, starting to use perfluorocarbon liquids to reattach giant tears was a breakthrough in the management of this break. A giant tear now without PVR has one of the best prognosis in all vitreoretinal surgery, but you have to be careful. Remove the hyaloid, inject it in front of the optic nerve head, and be very careful while indenting to remove either the peripheral flap or to shave the vitreous base to avoid fragmentation and subretinal slippage. Then it's better to avoid retinal slippage by injecting silicone oil and performing a direct perfluorocarbon liquid silicone oil exchange. Now what's more important in this talk actually is how and when to use perfluorocarbon liquid in non-complex retinal detachment. retinal detachment العادي اللي بيجي لنا كل يوم. First, you can use it to stabilize a very mobile retina, allowing you to perform steps like traction on the retina. Traction on mobile retina is not effective actually in removing the posterior hyaloid or epiretinal membrane, and sometimes it is even dangerous. Here, the retina being very mobile may induce an iatrogenic tear in the retina, but when I stabilize the retina by injecting perfluorocarbon liquid on the posterior fold, and I can go quite easily to engage and remove the posterior hyaloid, whether by tennis scraper, by suction, or even by forceps, and this is kept until all the posterior hyaloid is removed. In this case, I remove the posterior hyaloid to allow internal limiting membrane peeling. Sometimes I put perfluorocarbon to facilitate internal limiting membrane peeling, and I'm not with or against its use for peeling of ILM. Just tailor the use of this liquid in this situation to the needs of this particular case. Being heavier than water, it allows a more or less complete drainage without having posterior drainage retinotomy and without displacing the fluid to accumulate on the macula, producing the macular fold. So this is actually the most valuable contribution of this liquid to retinal detachment surgery. PFCL having a different refractive index than fluid and then vitreous allows us to identify the points of present vitreous gel inside the eye. These are marked by the yellow arrows. You can see there is a festooned line denoting the presence of vitreous, but actually it can do the same thing that may be better than this. As I told you, it can allow a complete drainage of subretinal fluid without performing posterior retinotomy that we used to do in the past. But to perform a near complete drainage without accumulation of fluid under the macula at the end, you have to tilt the eye to the extreme position, making the tape that you are going to drain through lowermost. So air is going to fill the eye from the opposite side, pushing fluid and perfluorocarbon in front of the retina posteriorly, and maintain drainage in the periphery till the retina is almost dry. Actually, ما فيش حاجة اسمها complete dryness of the retina. There is always a thin film of subretinal fluid. When to inject, you should not inject perfluorocarbon on the retinal surface except after removing the posterior hyaloid. Here, I thought I removed the posterior hyaloid. I started injecting perfluorocarbon. I did the same maneuver I'm using always, but you see that it was divided into frog egg-like bubbles. So I spent a long time removing these bubbles and restained. I found a layer of posterior hyaloid on the retinal surface. The presence of this layer of posterior hyaloid on the retinal surface prevented coalescence of these bubbles. Actually, if you have perfluorocarbon bubbles inside the eye and give them some time without no intervening vitreous, they just coalesce. Just keep the things quiet, and they are go together by themselves. The value of use of PFCL is not for free. It adds steps, injection and removal. And if you perform perfluorocarbon air exchange, you think that you are done. But actually there is a very thin layer on the retinal surface. In order to get rid of this, you have to inject some fluid on the posterior pole, just few drops. You find that what you thought is a retina free of PFCL, you find just a globule of PFCL on the posterior pole. If you wait for some time, the normally secreted aqueous will go to the back of the eye and let this globule appear for you. So if you want a complete removal, you have to perform it with a very little thin of aqueous fluid. Injection is another step. Here I am injecting using a special needle, but the injection was very heavy. There was a resistance. I expected a side gush, so I put my light in front of the injection. Despite this, fluid perfluorocarbon liquid rushed through the cannula, perforated the eye, and went subretinal and pushed even some air inside the anterior surface, in the anterior part of the retina. I have to remove this air and remove the subretinal perfluorocarbon. Actually, having subretinal perfluorocarbon is a nasty complication that you want to avoid at all costs. Having this fluid with a different refractive index than vitreous, than water, than air, creates a third interface that induces many reflexes, and sometimes these reflexes are annoying. So you have to redirect your light to avoid the reflexes. Actually, this is more than any reflex that you have during fluid air exchange without perfluorocarbon liquid. Residues of perfluorocarbon liquid inside the eye can occur. Of course, you don't want this to happen, but this bubble, I thought actually I removed the perfluorocarbon completely, but this eye was left air filled. This is what I told you a few minutes ago. The thin film on the retinal surface after the eye was filled with aqueous humor collected to perform this bubble. I don't know how this bubble found its way to the anterior chamber, despite the high specific gravity of this. But this bubble now is in contact with the endothelium. Actually, it is not very toxic, a bubble like this, especially that perfluorocarbon liquids are originally hydrogen carriers. I mean, they don't prevent nutrition of cells. Anyhow, I removed this bubble through the anterior chamber. The more dangerous thing is to have it subretinal, especially having a high specific gravity. It tends to go directly underneath the fovea. So it definitely will affect the visual function. And you have to deal with this if it is in the central fundus, but if in the extreme periphery, just follow it up. If it does not cause any inflammation, just leave it alone. If it starts to cause inflammation, you have to go and aspirate it. Here I am aspirating it with the 41 gauge cannula on high suction. How to prevent the frog eggs and perfluorocarbon from going underneath the retina? Now actually what I am doing always, I perform a partial fluid air exchange till most of the subretinal fluid is already removed. Then I start injecting perfluorocarbon under air, just to push fluid from underneath the fovea to the peripheral tear that I am draining through. Here I am starting drainage through the peripheral tear with the cutter. You see that air delineated the presence of vitreous gel that could be removed with the cutter. Then after complete removal of the peripheral vitreous, I used the rubber tip cannula to aspirate perfluorocarbon from the posterior pole, now having the retina almost completely dry. You have to avoid turbulence with perfluorocarbon inside the eye, using obvalve cannula, of course, at the lowest infusion pressure. You have to inject the smallest amount serving your purpose. You don't have to fill the vitreous cavity with perfluorocarbon. Usually, just to stabilize the posterior retina is okay, but anyhow, it should be below the tear edge. A very important thing to avoid frog egging and having subretinal silicone is to perform indentation to shave the vitreous base very carefully. And more important, to release the indentation very slowly. What happens when you release indentation rapidly is that the outer global wall expands, the retina lags a little bit, sucking from the vitreous cavity to subretinal space. Especially at this point, something else happens. When you release your indentation, there is a sudden hypotony that allows sudden egress of infusion fluid, inducing turbulence. So you induce bubbles and attract the bubbles to the subretinal space. So this movement should be very slow and very careful. And you have, as I told you a few minutes ago, to if you want to completely remove it, use a water drip on the posterior pole at the end of surgery. Having a low boiling point It evaporates during surgery under air, and it can condense, especially on the posterior surface of an intraocular lens, and sometimes even under the crystalline lens. If towards the end of surgery, just swipe it, and if you are going to replace it with silicone oil, inject silicone oil, so the droplet effect on the posterior lens surface disappear, and you have a very good view now, allowing complete removal of remaining perfluorocarbon under silicone. If you are not going to use silicone oil now, you can wipe it and insert a layer of viscoelastic on the posterior surface of the retina. Perfluorocarbon sticks to oil and sometimes making removal of silicone oil difficult. We remove silicone oil depending on the fact that silicone oil floats on water. But when it is adherent to perfluorocarbon, there is a cohesive force between perfluorocarbon liquid and silicone oil. It pulls this silicone oil back, letting silicone oil sinking and not floating. In this case, I found this problem, and I found a meniscus of perfluorocarbon underneath the silicone bubble that is now posterior. I just sucked the low viscosity perfluorocarbon. This allowed silicone to float, and I could remove silicone from the anterior part of the vitreous cavity. Perfluorocarbon liquids facilitate drainage of subretinal fluid, but actually you can perform almost complete drainage without perfluorocarbon by tilting the eye, starting fluid-air exchange, having the vitrectomy port close to the break. When the air bubble enlarges, you lose view for a while. Just keep stable, don't move anything, and keep sucking fluid. After a short while, the air bubble increases enough for you to see the drainage site at the end. So everything has to be performed patiently. You don't have to have a complete drainage, especially if you are going to leave the eye filled with gas. All what you need is to have the tear in contact with choroid to perform laser. Fluid in the posterior part of the eye is not important. Perform laser, have a reasonable gas bubble, and let the patient to have face down position for a while. This will push subretinal fluid out of the eye. I think this is enough for now, and thank you for your attention.
Next speaker,